Good evening. Welcome back to my IVF and the European Fertility Society. We are back with Dr. Antonio Carrillo. You can see him right here. Hello, Dr. Antonio. It's lovely to have you back. We've done some webinars with you before, so I'm glad that you are coming back, with this particular topic, which is definitely interesting and definitely a tough topic to discuss as well. How are you feeling? Great to have you here.
Hello, thank you. It's my pleasure to stay here with you. I want to thank you, your invitation, your opportunity to talk about PGT-A and embryo mosaicism, because I think it's a very important topic for those couples that are in the ART process. And I want to show something. I expect that it's very interesting for you.
I'm sure it's going to be an interesting session, but first, of course, remember, we will start with Dr. Antonio's presentation. Let me just remind everyone who hasn't had a chance to simply join our previous webinars with Dr. Antonio. He's the geneticist at Vistahermosa clinic located in Alicante, and he is definitely the right person to discuss PGT-A and mosaic embryos, because this is our topic. So as always, remember to simply put the questions in the chat. Everything is anonymous, so anything that's on your mind, anything that you would like to ask, you can type those in the chat section. Dr. Antonio will try his best, I'm sure, to answer and help you out with any questions that you might have. And remember, it's all being recorded as well and will be available on our website tomorrow. And I can only encourage everyone to simply type the questions. I'm sure it's going to be a great session. And thank you, everyone, for joining us. I know that you are coming from lots of different countries from Europe, but also US and Australia as well sometimes. So thank you so much for joining us. And I think that we can begin with our presentation on the topic. And as always, remember to put the questions in the chat, and we will take care of those after the presentation. And I think we can start. You can see the presentation, I believe.
Yes. Okay.
All right. Let's go.
Okay, so thank you for your kind presentation. And as I said, it's a very important topic, PGT-A and embryo mosaicism. And I want to start with a brief index, and I'm going to talk about ploidies, ploidy, PGT-A, mosaicism. We're talking about the guidelines from the societies of scientific societies. Some data and impact of mosaicism in ART. First of all, I want to show you what ploidy means. That's only is the number of chromosomes in a species. In the human being, we have 46 chromosomes divided into 23 pairs of chromosomes. The pair 1 to the pair 22, we call it autosomal chromosomes, and the last pair is called sexual chromosome. That is the difference between male and female. From the pair 1 to the pair 22, male and female are the same chromosomes, only the difference is in the sexual chromosome, because male we have one X and one Y, and in female have two X. That is the euploid. This is the euploid individual. This is the euploid for the human being. That's different. Instead, on the other hand, we have the aneuploidy situation. That means that they have, or the individual have the incorrect number of chromosomes. They have, in these cases, for example, we can see that this female have 3 chromosomes, 21. That's called trisomy 21, that provokes Down syndrome. Right now I have to tell you that there is only 3 trisomy that are compatible with life. The rest of the aneuploidy in the autosomal chromosome are lethal, and there is no individuals that have 1 chromosome 4 less or 1 chromosome 8 more. There is no people in the street with 3 chromosome 8. Okay, there is only babies born with trisomy 21 that called Down syndrome, chromosome 13 that calls Pateau syndromes, and chromosome 18 that calls Edwards syndrome. This is very important because in the embryo stage, only those embryos that have this euploid composition of chromosomes is going to do is going to achieve a pregnancy and a healthy baby. And how common is aneuploidy? Aneuploidy is very close. The relationship between maternal age and aneuploidy. I want to show you this graphic that it represents perfectly how aneuploidy in the embryos is growing up when going up the maternal age. Okay, in this case, when a woman have about 30 years, 31, 32 years, the percent of embryo of which aneuploidy is about 25%, but it's increased readily at 42 years, that about 70% of the embryos is are aneuploid. And here, luckily, we have a technique that allow us detecting aneuploidy. Okay, in the up of the slide, we have three similar embryos that are very good quality. Okay, but we don't know nothing about their chromosomes and the potential of the implantation potential of these embryos is not in his morphology. Instead, is in his chromosomic dotation or chromosomic composition. Okay, PGT-A is a process that we make in three stages. The first of all is the biopsy. Okay, I show you three kind of biopsy. Actually only the last one is the more used in nowadays. Okay, das embryo, it's called blastocyst, is day +5, day 6 after the microinjection. Okay, and we can see two parts in the embryo. The part of the peripheral part is called trophectoderm, and the inner cell mass that it's going to develop to the fetus and develop to the placenta. And in the day 6 or day 5, we can take about 5 to 10 cells to analyze it. I want you to remember that right now we can analyze 5 to 10 cells because it's important for the mosaicism concept. Many years ago, really not so many years, but in the genetic context, 10 years is a lot of the prehistoric of the genetic. Okay, we can do the analysis only in one cells. Okay, for this reason, 15 or 10 years ago, we don't know nothing about mosaicism because only study one cells. Right now, we can study about 10 cells. Okay, the second stage, we take the samples to the laboratory, to the genetic laboratory, when we make a process, and we use this platform that called, maybe you sometime hear this name, this NGS or next generation sequences, is the only platform that allow us to detect mosaicism. Okay, and the bioinformatica can ask the results. And we said, we can go to that. We can see that these three embryo, only one have the potential to achieve a pregnant or to implant in the utero when we make the transfer. Because the number 2, we can see here that there is a trisomy of chromosome 22. Briefly, there is one chromosome in red, one chromosome in blue, chromosome 1, chromosome 2, 3, and there is, in this line, we have 2 chromosomes. Okay, one line up is 3 chromosome of trisomy, and one line below is a monosomy. Okay, in this context, embryo number 2 and embryo number 3 don't implant after the as the transfer in the utero, the modern utero. Only the number one has the potential to get pregnant and to develop to the healthy baby. And what is the importance of the PGT-A, or the benefits of the PGT-A? The PGT-A in women over 30 years of age can mitigate the effect of maternal age. I show you this graphic that we can say how the implantation rate go down in every range of age of the maternal age. Instead of the PGS, PGS is the legacy name for PGT-A. Many years ago, we call it Preimplantation Genetic Screening. Right now, we call it Preimplantation Genetic Test for Aneuploidies. Okay, but when we make a PGT-A or PGS cycle, the average implantation rate is the same in all group of maternal age. Similar is for the miscarriage rate. In this case, don't increase with the maternal age. It's about stable about all the maternal age range. This is the principal benefits of the PGT-A. And here we have, if you remember, I said you that when we analyze only one cells, we have only two possibilities: euploid or aneuploid. I'm sorry because I have an animation that is not in this PowerPoint, and here maybe may appear a mix, an embryonic mosaicism occur when the two or more cells population with different chromosome number are present in the same embryo. I'm sorry, but there is only another picture where we can see red and blue in the same embryo. That is mosaicism or mosaic embryos means, okay? When we detect, or we can detect, these two or more cell population in only one embryo. And we can do it because the improvement technology. We can do it because NGS, next generation sequencing, allow us to detect this situation and the biopsy of the trophoctoderm. Mosaicism is common, not so common, but it's important that it's similar across all age range. It's about 15% in all range, okay? And for this reason, this topic is important not only for maternal age, advanced maternal age, is important too for women under 35 years, because the percentage of mosaicism is about 20% in this range of age. The important of the mosaicism, someday one group decide, in a couple that don't have any or don't have more euploid embryo, they decide to transfer one mosaic embryo, and this mosaic embryo transfer ends in a healthy baby born. And then all the groups, it's opened the door to all the groups to use these mosaicism embryos, because 20% is a lot of embryos that are mosaicism that at this moment we don't transfer. But when they show that the transfer of the embryo mosaicism, the mosaic embryos get a pregnant healthy baby, all of the groups try to do it. And in this moment, the scientific society make guidelines to helps doctor and helps patients to determine how or which mosaic embryos transfer. Okay, and this is one of the latest society guideline from Preimplantation Genetic Diagnosis International Society, or PGTs, and it's a simple graphic that is very useful for me in when I make up post test counseling for explain to the patient the risk for transfer one embryo mosaic things, mosaic embryo. Sorry, we can see here in green a safe option. It's a safe option, and less safe or unsafe when you turn red. Okay. Here we can see the level of mosaicisms. The level of mosaicisms is the number of cells of the embryos we suspect that have mosaicisms. 50% means that the embryo the half cells of the embryo are euploid and the half cells of the embryo are aneuploid. Okay, you can see that from 20% about 50% is safe. Is safe means that if we achieve a pregnancy, the baby will born healthy. Okay, but it's associated to some risk. Okay, some risk like less beta rate, less implantation rate, more miscarriage or miscarriage rate, and less live birth rate, and increase when more is the level of mosaicisms. Okay, to help more, we have a pyramid that say that which embryo transfer first. Okay, the first of all we have to transfer is euploid. It's obvious. Then we have to transfer mosaic level segmental. In the next slide, I explain you what does it mean. Low level mosaic for one chromosome, for two chromosomes. Okay, in definitive, we are not alone against the decision of transfer or not transfer the embryos. There is a lot of works about this and the risk evaluated for a lot of groups, of UR groups that have a lot of experience. And this is only I want to show you what segmental aberration means. I said that the second one you have, or we recommend to transfer is a low mosaic low segmental. I say that aneuploidy means that we have one more or one less chromosome, but NGS again allow us to detect not only the gain or the deficit of one chromosome. Instead, we can detect only if we can detect if they have a loss of a segment of the chromosome. We have a lot of resolution. Okay, the deletion and duplication. We have the 46 chromosome, but in one of them loss or gain one segment of these chromosomes. Okay. And SRED, that is the society that follow us in Europe more than American. They have a very clear recommendation. Better not recommend it. Okay, when we detect mosaic or low range mosaicisms, low range established in below 50% of mosaicisms, the PGT-A should be co-evaluative with morphology. Okay, and it's not recommended any stimulation cycle when we have this kind of mosaic embryos. Don't recommend the discard low range mosaic embryos, and don't recommend rebiopsy these embryos because it's clear that there is no risk for the future baby. Okay. In summary, all this scientific organization guidelines recommend transfer the embryos when it's a possible low-grade mosaic established at less than 50%. Before transfer the embryo with a partial or segmental mosaic versus full chromosome mosaic, embryos with possible single chromosome versus complex is more than 3 chromosomal alterations. In this case, embryo transfer is considered safe. Okay, in the terms of the baby. And although it is important to emphasize that importance of the prenatal testing, yes, it's mandatory to do a prenatal testing. Is it different? When I talk with patients, I say that the difference, the main difference between transfer mosaic or transfer euploid is the importance of the prenatal testing. Is mandatory or very strong recommendation to do a prenatal testing that we talked about this before after, sorry. In case where the transfer is more than one mosaic embryo for transfer, it's recommended to embryo to transfer the highest morphologic or morphokinetics quality. Okay, and in our group we show in our PGT-A genetic report those mosaic, and we make the recommendation in these reports, and of course we offer a post-test counseling appointment to explain all of this. And what is the impact? This is, I think, this is more important for us. What is the impact of the mosaic themes in ERT treatment? In the start of the mosaic theme transfer, there was BOT et al. That's a very strong group in reproduction. They show, or they find that they transferred 1,000 mosaic embryos, and they show in this graphic that there is impact in the implantation rate and the ongoing pregnancy rate, okay, and two in miscarriage or in the pregnancy loss. There is less possibility that in implantation or in ongoing pregnancy life birth. Sorry. Then they conclude that the mosaic embryos that have high rates of miscarriage, they have high frequency, experiencing high rates of miscarriage than euploid embryos. But very important, the infants born of mosaic embryo transfer are similar to infants of euploid embryo transfer. This is the most important, I think, that that we have to do in or to get to home. That's more important, okay? Because the most themes resolved during the most pregnancy, okay? When they examine the amniocentesis, they don't see the mosaic themes in the fetus, okay? Only a very low percentage of cases the mosaic theme persists. So, to my concern, in the bibliography, there is only 4 cases in all the world that the baby born with the mosaic theme that detecting PGT-A. Only 4 in all the transfers that we made in the world. Okay, and we go on with the investigation or the impact of mosaic themes in IRT, and the Jekolev shows that it's very interesting to assess the transfer mosaic theme in a threshold of 100% of mosaic themes. And I don't know if you can see, but that means in the implantation rate in euploids or embryos below 50% of mosaic and more of 50% of mosaic, it is the same. It is the same ratio, as the same implantation rate and the same ongoing pregnant. If the threshold is 60%, this is there is difference, okay, that we saw before. To finish with Antonio Capalvo and et al. That they find difference in positive pregnancy, biochemical loss, miscarriage, and live birth rates between the groups. What groups? This group. Group A, they transfer only euploid embryos. Group B, that transfer low-grade mosaic embryos, 20 to 30% variation. And Group C, the medium-grade mosaic, from 30 to 50% of variation of mosaic themes. And they don't find any difference in positive pregnancy test, and the most important in the live births is about 40% in all the groups. That is a very important, and is very helpful for us, because Antonio Capalvo demonstrated that there is no difference in pregnancy and healthy baby when we transfer and embryo mosaic less than 50%. I don't know if I can if I can explain you this graphic, but for this work they make this mathematical model when we can see the percentage of live birth rate, not pregnancy rate, live birth rate of healthy baby, when we transfer only embryos with less than 20%, and we transfer all the embryos less than 50%. Okay, that's mean that women with 38 years, is we only transfer euploids, have a percentage of live birth rate about 35%. But if we transfer all the embryos, including mosaic, low-grade mosaic things established in the 50%, it's about 55%. It's very, very important. And the most important, this is work from here for Grupo UR and Numa Genetics, that we report the 10 first mosaic embryo transfer. We have 7 pregnancy, totally healthy babies with 3 birth, totally normal, like I said, babies normally. Okay, and this is very important. I think that is fundamental for take decision, because when you do a IVF treatment, you are expecting to have at least one embryo to transfer, one euploid embryo will transfer. If this a hope to the couple that don't have euploid, but they have a low grade embryonic mosaic. But it's very important to take this decision to explain what is embryonic mosaic things, like we saw today, what is the clinical impact, the limitation of mosaic embryo transfer. Okay, we have 2 scenarios, like I show you, Capalbo and BOT. We have to say that nowadays we must be cautious, and we have to say to maybe you have decreased implantation rate or increased micro rate in the worst of the case. But other people say that it's the same, the transfer of euploid or the transfer of low grade embryos, mosaic embryos, sorry. Probability of being a false positive, this is the key question, because I show you then that maybe mosaic things maybe are a limitation or technical limitation, and it is artifact of the technique. Okay, I show you then. It's absolute need for prenatal testing. This for us is mandatory. Okay, in the way of non-invasive prenatal test, maybe it's enough, or amniocentesis. We discuss is later. And report mosaic pregnancy low follow a very similar evolution to non-mosaic pregnancy. I told you that I know 4 cases in all bibliography. Okay, there is a very good work for Gerard Campos that said it's the time to stop report mosaic things. Okay, why? Because mosaic things should not be reported only because it is observed. Okay, we have reported if it had clinical impact. If it not have clinical impact, maybe we don't have to report only because we observe it. Okay, because this generates confusion among professionals, making it difficult to manage and leading to the discard of healthy or potential healthy embryos, and unfavorable effect on patients' anxiety derivatives, and for making a decision of the risk and necessary prenatal testing. And NGS have proven to be clinically useful for the diagnostic of euploid and aneuploid. It's less useful in mosaic. And in this, in our group, we think that it's better to know than not to know. And then, if you have a counseling, a post-test counseling you can resolve off, or you can lower the level of anxiety because you are taking this decision with information, okay? And that's that you said before that the low-grade mosaicism maybe are euploid embryos with some artifact of the technique, and high-grade mosaicism more than 50% maybe are aneuploid embryos with a technical variation or a technical limitation. Okay, it is a good topic or good thing to think about, but I think it's a good work that I want to show you. And if we're talking about transfer embryos with some kind of chromosomal alteration, we can think what happened with aneuploid embryos. Can we transfer these embryos? No, the lethality rate of the aneuploid embryo is near 100% in all of the work that is published. Okay, and then establish the threshold for the embryo transfer about 50%, in no more. Okay. Prenatal follow-up. I said you that we can make this not the best option, okay? But nowadays, NIPT, non-invasive prenatal testing, we can make it in the 10th week of the pregnancy, and it's a very good screening. Okay, not diagnostic, but it's a very good screening. Always that we can analyze the 46 chromosome, the 23 pairs of chromosome, because there is in the market there is some NIPT that only study the chromosome 13, 18, and 21. That kind of tests don't valid. But if there is another test that can screen all the chromosome, that the kind of test that we have to do. And the only diagnostic process today is the amniocentesis that we can do it in week 16. Sorry, it is in Spanish. In 16 week of pregnancy, and we can make an array CGH, it's comparative genomic hybridization, that we have diagnostic of the, and we can say if the mosaicism is still in the fetus or not. The last, to take home some message that aneuploidy is common in the first stage of embryo development. Autosomal aneuploidy do not result in healthy pregnancy. Aneuploidy is more frequent in advanced maternal age. PGT-A can detect embryo aneuploidy before transfer. Mosaic embryos transfer less than 50% is a safe option for those couples that don't have any euploid or don't have more euploid embryos. And some groups say that mosaic embryo transfer result in worse reproductive outcomes. Others say that the result are the same in euploid embryo transfer. And prenatal follow-up recommended if mosaic embryo transfer resulting in a pregnancy. That's all I want to show you. This is Alicante, where we are. This is Numa Genetic, the genetic department of Grupo UR Internacional. And these are my colleagues. That's a very good team. And I'm very grateful for their work. Thank for you. Thank Caroline. Thank for you. I try to answer all your questions.
Brilliant. Thank you so much indeed. It was an interesting presentation for sure. And I know those are not, sorry, can you see me and hear me? I hope you can.
Yes, I can hear you.
Sorry. So basically, I just wanted to say thanks for bringing this presentation and this topic to us as well, because this is a complicated one, that's the truth, but I'm glad we were able to, at least I hope that it was clear for you. And now we are just simply going to answer some of your questions. So as always, please type those in the chat, and Dr. Urbano will be happy to answer them for you. So let's start with the first question that we have. I will show it to you. This is a short question. Can a blastocyst with monosomy of 4th chromosome give a healthy baby?
No, Olga. If the monosomy of chromosome 4 is complete, there is no possible. Okay.
Okay, so it's
It's
thank you
great.
for the first question.
Okay. Well, in biology or in genetics, always not only is white or black or white. Okay, not black or white, but I can answer you if the monosomy is pure. It's 100% of the cells of the embryo is one fourth less. There is no implantation or pregnancy loss in the first stage of the pregnancy.
Okay, that's quite clear, I believe, of course. Thank you for your question and help with that. Now we will go for a few details from Celine here. I have a long IVF story, 8 IVFs with bad luck with choice of the first clinic. Now I have only one mosaic embryo. After my PGT test, it was a 4AA embryo, and the result is M18 mosaic monosomy 60%. So is there any chance to have a healthy baby?
Okay, Celine, in this case, 60% in our group, we decide no transfer. In more when it's involucrated 18 chromosome because trisomy of chromosome 18 can develop to Edward syndrome. Okay, it's true that it's a monosomy that is a limitation in the technique that sometimes we can see that it's a monosomy, but really in the fetus is a trisomy. Why? Because I said that a study first from the trophectoderm that it formed the placenta, okay, and we don't know 95% is the same chromosomes in the placenta and in the fetus, okay, but the 5% that is not the same, and chromosome 18 in 60%, you can transfer, but mandatory prenatal test.
Okay, yeah. All right, thank you so much. I think again that's a clear message here. I hope again, Celine, that answers your question. I do believe so. All right, so let's have a look at this one, okay? So please, can you talk about HLM as these still have chances of success? Why discard them, especially when women over 40 struggle with making embryos?
I have a problem. I don't know what actually.
I
Sorry.
have a problem, I'm afraid, as well, but I just wanted to see. But in that case, Natalia, if you could please let us know exactly,
I'm sorry, Natalia.
then I will be happy to go back to this
Yes,
question.
I'm
High
thinking
level, all right.
the case before. I have to say that in our group we don't recommend high grade mosaicisms. Okay, but I know that there is another group that can transfer it. Okay, but we don't recommend the transfer when the threshold is more than 50%. Okay, because the risk is higher, and there is no a lot of data like in the low grade. Okay, there's a lot of data of low grade mosaic transfers. No hay tanto, o sea, there is not a lot of data of high grade embryos transfers. Okay, this is more cases than low grade mosaic. Okay.
Okay, of course. Again, thank you so much for this. Those are never easy questions and not
Yeah,
easy
yeah,
answers, I'm
yeah.
afraid, right? This is the case here. All right. Next question. Again, an interesting one. What can be the reason for an inconclusive, noisy profile of PGT-A
Yeah.
results?
In one of the graphic I show you, there is about 3% of the embryo that don't have result, and this is for various. It can be for the DNA are degraded, the embryos it's no good quality, or the noisy of the technique inside. There is a problem. This we can't do anything with it noisy because very low grade most of things is very probably that is noisy. Okay, in some way we are overestimating the really or the realistic embryonic mosaicism, but this is the handicap that we have right now. But all the works, all the papers, all the bibliography study with the hypothesis that if this is a technical noisy or technical limitation, the embryo is good and we can transfer, and we show that the embryo is good. It's really good. Okay. And then in the question, I think that I don't answer the question. Sorry. I want to explain the noisy and the
Sure.
here. Okay.
Sure, I can. No problem.
Can be the
So-
reason. Yes, yes. This is the reason. Okay.
Okay, thank you so much. There's one more question here as well. So please let us know if you have more questions. You know what to do, type those in. You already mentioned this, but I think, this is a topic we can still explain, right? So what is the cause of mosaic embryos?
This is a very good question. There is hypothesis. It's known that the human being is very bad species for reproductive in the reproductive way. We are very bad at reproduction, and in the first stage of the development of the embryos, the embryo is dividing himself very quickly. Okay? They don't. When we are adult or when we born, we have a very mechanism to detect aneuploid cells and kill him. Okay, but when in the first stage of the development, the, seems that this mechanism don't work, because the only thing that the embryo is thinking is I'm going to implant, and I need a lot, I need grow up, and I know I don't have time to look at which cells are bad, and I kill him. I will kill them in the post when I implant. Okay, when I implant, and then this is a hypothesis that I when I go in some congress, I said I have one presentation that I have in my memory that is very very good and very can explain very good this topic, because they they led the embryo to the day 12 of the develop. Okay, the embryo was aneuploid, and they allowed to develop to the day 12. All the pure aneuploid embryos seguían. They show aneuploidy on day 12, and all the mosaicism embryos in day 5 were euploid in day 12. Some mechanisms that the embryo can correct the aneuploidy. Okay.
Yeah, of course. This is and again interesting. That's why they are still, of course, transferred, right? Some of those, because they can still correct themselves, right?
Yes.
All right. That's why it's tricky. That's why it's not easy to answer that.
Yeah,
Right?
but they can correct when they have some cells that are good. Okay, so if all the cells are bad, you can't correct anything.
Of course, that's the truth. One more question shown here from Salia with some background as well. So let's have a look. Okay, this is also as well interesting. My question is, so is age the only real condition for having a baby with problems? I'm 46. I never drink alcohol, never do drugs. I never smoke. I have always been like this. I have all my vaccinations. My favorite drink is milk. I eat quinoa. I never had any miscarriage, never taken birth control. I only use progestogel, 1 gram, right? I think from 2 years ago. I need excellent sperm of great quality, and I'm young, I think, as well as healthy, and I think that is all. So is this logical? If you can perhaps try and clarify a bit as well.
Natalia is a very healthy woman. It's very good. No, the problem with the maternal age is the chromosomal. So the chromosomal. There is a lot of disease that there is nothing to do with the chromosome. The maternal age is close relationship with the chromosomal aberrations. Okay, Down syndrome, Edwards syndrome, or Patau syndrome. There is increase a lot when the maternal with the maternal age, but there is a lot of disease. For example, you can or it's I thinking in outings, for example, or something problem of the neurodevelopment. There is a lot of genes that in this that a lot of genes um, that predispose you to have this disease, but not only the maternal age. Okay, maternal age is related with the chromosomal aberrations.
That's the problem, the main problem, of course, here. Thank you so much for the clarification. And let's have a look. There are a few questions in one, okay? But let's start with this one. Okay, sorry. Here are questions I'd like to ask. So, segmental aneuploidies and full aneuploidies. So could you explain how segmental aneuploidies differ from full aneuploidies in terms of their impact on embryo development and implantation success rates?
Okay,
Let's start with this one.
Okay, this is because I said before, maybe because this is an artifact, and this is more es more probably that segmental aneuploidy is an artifact more than full aneuploidy. Okay, this is only for the terms of the technical limitations.
Yeah. Okay.
And the second?
Oh, sure. Sorry. I just need to show this once again. Sorry, it disappeared for me. It's right here. Just give me a second because I cannot somehow do it, but I will. Okay, sorry. Here it is. So are there like does the current PGT-A technology is equipped to accurately differentiate between segmental and full aneuploidy?
Yes, we have a limitation threshold that is lower and lower in every revision of the kit, but we work about 10 megabases. That it's similar. Like if you remember, I show you a chromosome that it's divided in two parts, in two arms, short arm and long arms. We can detect perfectly the deletion of the one arms or the duplication of one arms, and this I don't know how to explain. We can detect with a very sensitive. Okay, this, with a threshold, we have a limitation of about 10 megabases. This half chromosome approximately. We can do, or we can push to detect 4 megabases. That is less, but there is to put it in context. There is a lot of the disease that is provoked with for the deletion of, because the deletion of only 1 megabases or half megabases that we can detect right now in the PGT-A, in conventional PGT-A.
Of course, that's the main problem, I would say, right here. Okay, thank you so much. Again, someone is typing, so let's give it a minute. We will be slowly finishing, so if there's anything else you wish to add, just go ahead, type this in. If not, we will be finishing, but I just want to make sure that we've answered all of your questions, and I know it's not an easy topic as well, so let's give it a second, and someone just showed the next question. So does it mean that IVF with PGT-A has more chances of being successful?
Oh, this is a very good question, and then we can do another webinar if you want.
True. True.
I think that is improved the results. Okay, not only improve the result. There is nowadays a discussion about the utility of PGT-A, but it's very clear that an aneuploid embryo don't achieve pregnant, don't implant. Okay, this is we know it perfectly. The only thing, the only technique that we have today to detect that aneuploidy is the PGT-A. Maybe you don't have more live birth ratio, because if you have four embryos and you transfer the you have four embryos and there is only one euploid embryo in these four. If you transfer the four, you transfer the euploid and you get pregnant. Okay, but if you make a PGT-A technique, you can select this only one PGT-A, transfer the first, and you short the time to get the pregnancy. Okay, and for my opinion, the PGT-A improves the IVF results.
Thank you so much. It's just saving time sometimes. If you have 4 embryos and 3 of those are, as you said, are aneuploid, you will not need to, you will know that there's no chance, so you won't transfer
Yeah,
them.
you don't have to transfer an embryo that you don't have any possibility to get pregnant.
Exactly.
It's important.
Exactly. So I think that's really helpful tool for sure. So thank you so much for the clarification. And what is the risk of a false positive aneuploidy result in PGT-A?
Yeah, it's a very good question too. The false positive aneuploidy is I want to say that the false negative is near to zero. Okay? If the PGT-A is normal, the embryo is normal. False PGT-A, that's called positive predictive value, is high too, about 80%. I don't know the data right now in my head, but I think that is about 80%. But it's a very good. It's a very good. When we have a very, it's that I said before, there is no white or black. Okay, if the sample is good and the technique is good, the positive value is near to 100%. Okay, maybe when we have a noisy ratio, a high noisy ratio, or something wrong with the biopsy or with the DNA, something that can puede pasar, sorry, can happen. Sorry, can happen. It can happen. The positive predictive value can be lower. Okay, but it's very high. And always when you get a PGT-A, you get pregnant, always before recommend prenatal test. Okay, to get and before this there was a controversy if it's a magnetocentesis necessary or not, because there is a couple that have a lot of difficulty to achieve the pregnant, and they don't want to hear nothing about amniocentesis. Nowadays we have the non-invasive prenatal test that this is not the best choice, but it's very good. It's a very good solution for this kind of couples that PGT-A we recommend to NNIPT test.
All right. Again, thank you for the clarification. I believe that was our final question. Someone is typing, so I want to make sure that we've answered your questions. But I already think it was a great session with lots of interesting information and useful information. So thank you so much, Dr. Urbano, for joining us today and for your expertise and sharing your knowledge and your experience with us as well here. Any final words before we finish for today?
Okay, thank you so much. I'm here for whatever you want, and any question that they have, the people can contact with me. There is no important, and I want to focus on the genetic counseling. Okay, there is very important to make good decisions to lower the anxiety in the couples, and this is very important. If you have the opportunity, get a genetic counseling appointment, because this is the professional that can explain you more deeply the significance of the mosaic or another genetic disease. Okay. And thank you
Definitely.
so much, and thank you for your work and all the people that listen to me. And I hope that I can help you. And, and
Thank you so much indeed. I do think that was useful. Thank you everyone for joining. Looking at the questions, I know that you've got some answers, so that's why we are definitely here. We want to talk about PGT and mosaic embryos, so we want to make sure that this is also understandable for you. So thank you so much everyone for today. As you know, we will be back with some more events. Dr. Antonio Urbano has been our guest speaker today, but as you know, we will be back. So thanks a lot, everyone, for joining us over and over again. We will be back next week with some other topics. So I hope you will be able to join us. And of course, this event has been recorded and will be available on our My IVF Answers website, as well as our YouTube channel. So you can subscribe, and that way you will be notified that the video has been actually uploaded. Thank you. Have a good evening and see you back here, I hope, quite soon, Dr. Urbano. Thank you so much. Take care.
take
Bye.
care. Bye.
Bye.